Hello to all of you. This will be my first video presentation on physiology, and this video presentation is dedicated to Kyrgyz National University, named after Jasab Balasagan. And this video presentation is made under the guidance of respected Gulnara ma'am, our physiology teacher. And my name is Vardhan Ravindra Pathik, Group 4th B, second semester, first year. So, today I'm going to discuss in this video presentation about modern method of study of heart, right? So, let's look forward into the topic. So, in this topic, we are going to discuss about the modern methods which help us to study heart activity and other electrical and sound activity of the ECG as one of the informative methods for studying the properties of heart, auscultation of heart sound, and phonocardiogram as a method for examining of heart. So, what is an ECG? An ECG is a non-invasive medical test, right? Non-invasive, it means that in ECG, no one is going to penetrate through your skin or through your openings and device or something like that. It is non-invasive. Some plastic patches put on several points of your body, like your chest, your left limb, right limb, uh, like left upper limb, right upper limb, and your uh, leg, right? One of your left leg. So it is the medical test that uh, that measures electrical activity of heart, right? It records heartbeat and rhythm. So if there is something wrong with your heartbeat or rhythm, you will get easily know about it when you take ECG of the patient. And so when we discuss about why is an ECG used, so diagnose an ECG diagnose, monitor the cardiac conditions and detect the disorders like arrhythmia. If any there is something wrong with the rhythm of the heart, maybe for example any wave in QRS complex or P wave or T wave is missing or delayed or premature, then you will know the disorder. Arrhythmia, heart rhythm disorders, these will be detected by ECG, right? So now I'm going to discuss the ECG in detail, uh, and I'm going to draw a plot about ECG, and then we will discuss how we can measure the ECG, right? So let's start here, right? So here shown like it's a slice of your heart, and you can easily see here your SA node and your AV node, and then bundle of his and Purkinje fibers, right? So let's discuss about that how ECG works. Actually, there is a concept of vector, right? I'm gonna write vectors, right? So let's see about it. Vectors is nothing but the direction of the electrical activity where it is going, right? Let's see a small concept, right? Uh, let's say, let's say I'm drawing a tissue, right? I'm drawing this tissue. This is a cardiac tissue, nothing but the cardiac tissue. And obviously, it is a nodal cell which can generate impulse by itself. So I'm going to put my electrodes here and here. Like, uh, let's say I put here minus electrode and here plus electrode. Right now, this tissue is going to this cell is going to generate its impulse by itself. Right now, if if this impulse goes into the direction of positive, it will give our it will give us a positive deflection, right? It will give us a positive deflection like this or like this. This will give us a positive deflection, right? If this go opposite to the positive or away to the positive or towards negative, it will give us a negative deflection, right? It will give us negative deflection. And what if it stop it stops or slow down, then it will give us a flat line, right? And if the direction of this electrical activity per- perpendicular to the electrodes, like here my here are my electrodes, and the electrical activity is going here or there, then it will give us to a like this perpendicular line. See, now maybe you can connect it to the QRS complex or the whole ECG, right? Now I'm going to draw this. This is your E wave, and this is a flat line. We are going to discuss about all everything. But here's a preview. Here's a preview of how QRS complex and how this ECG whole wave is work, right? So uh, now you can see here are some positive deflections, negative deflection, and flat line, and also this perpendicular line which shows us to that the electrical activity is perpendicular to the electrode. Right now, I'm going to clear all my drawings. Now, let's start with the our first wave, which is P wave. Right now, let me show you. I'm going to put second lead. Right. Okay. Maybe this is a bit confusing, but remember there are 12 leads which helps us to detect the ECG. But in this segment, I'm just going to talk about the second lead, right? Secondly, we will discuss all the leads, but for now, just second, right? So I'm going to put my electrodes like that. Right? Here will be my positive electrode, and here will be my negative. Positive to the apex, and obviously negative towards the base. Right. Now, impulse will start here, as we all know that SNO generates the impulse, and this is going where towards the AV node, right? Towards the AV node. From SNO to AV node. First impulse is going, and where it is going? It is going towards the positive. As I mentioned before, if the impulse is going negative to positive, towards a positive, we will have a positive deflection, right? So from starting, here we are going. Sorry. So, oh, sorry. Yeah. So from this segment, we are going to see our first deflection, which is positive, our P wave, right? This will our P wave, right? From here, now, first wave is completed, P wave. Now, we know the AV delay. We know the AV delay, right? We know the AV delay. AV delay will accumulate these electrical activity for a few fraction of movement, and this will lead to a flat line because here the impulse is stopped, right? So this is going to be like that. First P wave, then a flat line, right? This is the P wave, and then a flat line because of the positive charge is going nowhere but stop, right? I already mentioned that when we get the flat line, and here's the moment when we get the flat line, right? Now, if we talk about now, if we talk about the third stage is going to be a different, right? Now, impulse is already accumulated here. Now it is slowly going down, slowly going down, right? In a third stage, it's slowly going down. But here's a twist: the septum needs to be depolarized, right? This is intraventricular septum, and this needs to be depolarized. But this is depolarized only by the left bundle branch, right? We all know that bundle of his will divide into the right bundle branch and the left bundle branch, but this septum will depolarize only by the left bundle branch. And this depolarization is going to be in that direction, right? Perpendicular to this electrode, right? Perpendicular to this lead, right? uh, I should have mentioned that if we put electrodes plus and minus between there, obviously we will get a lead. So this is a lead, and perpendicular to lead we are going to get a perpendicular line, right? So here P flat and perpendicular line. Now, let's, it's time to name them, right? So P wave here is the end of the P wave, or we can also say, obviously, atrial depolarization, right? Now, this segment is going to be our PR interval, right? This is the interval. This is our PR interval. Now, this wave is Q wave. This is our Q wave, right? Only this segment. This is our Q wave. Now let's talk about this. So now waves are coming here. Now electrical activity is coming here. Let me explain it. Let's take a segment. Now the impulse coming here. Now left ventricle is thicker. We all know left side is thicker, very thicker than our right side. So if we talk about the vector, if we talk about the vector, some electrical activity is going here, but most of the activity is going here because our left side is dominant, left side is thicker. So if we draw this, this is more prominent side. Now, because of this, the resultant will be here somewhere, right? Towards the positive. So if we get a positive, if we get our electrical activity towards the positive, very intense, so what will we get? We will get a positive deflection, and a very big positive deflection. So let me draw here P wave interval, your perpendicular, and this is your positive deflection, right? This positive deflection, we will call it R wave, right? We called it R wave. Now, positive charge is accumulated here, right? Positive charge is accumulated here, this side, right? When the positive charge is accumulated here, it is going to upside, right? It is already accumulated here, and now Purkinje fibers is going upside, right? Upside of the ventricle. So the net vector is going upside. Whoa, this is against to the positive charge. This is against to the positive charge. So away from the positive charge will be result into the negative deflection. Let me draw here. This is P again interval, perpendicular, R wave, and this is going down, negative deflection as your S wave, right? Again, this is your S wave, right? Now, if we talk about here, there is going to be again a time period, because it is the time now we need to repolarize, right? We need to repolarize things. Why? Because it is already depolarization already done, right? Everywhere is positive charge. Now it's time to flip the charge. It's time to flip the charge and repolarize the ventricle, right? So during the repolarization, this charge will reverse, right? This positive is going to become negative. But before that happens, before that, what is going to happen is again a delay, again a segment of flat line, because this flipping will take a few moments, a few a, a fraction of a few moments, right? So this this and a flat line which will indicate us that there is a delay. Now a T wave, here's the T wave. Now our this is our ST and this is T wave, right? This is our T wave. And what the T wave is showing, that its whole charge is flipped into the negative charge. And now this negative charge will move toward negative, right? Or away from the positive, right? Look, when the negative is going away from the positive, right? Then it will result into the positive deflection. Okay, again, if positive charge is going towards positive, it is positive deflection, and if negative charge is going away from the positive, it is also a positive deflection. So have we have the complete wave, this 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 and our QRS complex and T wave. So this will gives a whole information about our electrical activity of heart, right? Now this is just about the ECG. Now let's see how we can take the ECG, right? Let me clear this all drawings. Now I'm going to talk about the leads, right? Let's talk about the lead. So let's talk about the leads, and these leads are 12 in number, right? 12 leads and three types of leads. Three are bipolar lead, bipolar limb lead, right? Uh, Three are augment, augment, unipolar lead, and six are your precardial precardial lead, right? Which is going to be put on your chest. So uh, six are precordial chest leads, right? Bipolar limb leads are your 1, 2, and 3. Unipolar augment leads are AVF, AVR, and AVL. We will discuss about it. And the chest leads from V1 to V6, right? Now let's discuss them one by one, right? Let me show you here. The first we will start from the bipolar, right? These are the bipolar leads, right? For that, we are going to put an electrode here, here, and here, right? Three electrodes, 3 points, right? Let me show you. So for this, I'm going to put a negative electrode here and a positive electrode on the foot, and again negative electrode. I'm sorry, positive electrode here, right? Now let's see. From positive to negative, this will be a lead. This is going to be our second lead, second number lead, right? We have already discussed about the second number lead. We will know more about it in this segment. The second lead, uh, by which we have covered the all ECG cycle, right? Now, this is going to be our first lead, And in order to get the third lead, I have to put an positive electrode here and negative electrode here. This is going to be my third lead. Now let's see. Now let's see. This triangle, in this triangle, we have some views. Let me tell you, bipolar and augment lead will give you bipolar and augment lead will give you the frontal view, and this our chest or precordial lead will give you the horizontal or transverse section of the heart, transverse view of the heart, right? So here, negative, positive, 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 negative, right? So we have got all the three leads, right? Now let's think this second lead. Here's again one more concept, that a view of heart is when you see, put yourself on the positive side and see towards the negative side, right? Let me tell you, second, third, and first, right? If you see first, if you see positive to negative, if you see positive to negative, right? You are going to have our first view, right? You are seeing for bottom to top, and this is your right side. This is your left side, right? This is your superior view, right? Now you are seeing from left to right here, inferior to upside here, and also inferior to upside here. Now, the first lead will give you the view of left to lateral, right? Left to lateral view of heart. Second lead will give you right inferior, view. And again, third lead will give you left inferior, view, right? So this is about three leads of bipolar. Now unipolar lead. Unipolar leads are like that, resultant vector, right? Positive, negative, negative. Now in this segment, I am going to have a specific point of the heart. Now negative will result here. Now this is going to be your first view, right? AVR, augment lead from right side, right? Now look here, this is positive, negative, and negative, right? Now resultant will drop here, but as I mentioned that we are seeing from positive, so it is seeing from foot. Now this will be called as AVF, augment from left, right? From foot, sorry. Now negative, uh, negative and positive, resultant will be like that, but we are seeing through here, so this will call AVL, augment from left, right? Now let's talk about the chest. uh, when we discuss about the chest, uh, we put precordial lead like that way. This is your external angle, and uh, through external angle we can know the first rib, and we will come to the your intercostal space, like we will count 1, 2, and 3, right? So first we are going to put our One, two, three, and fourth intercostal space. Right, right side V1 and left side V2. Right, V1 and V2, right side and left side, fourth intercostal space. Now, for V3, we will wait and put V4 mid clavicular line. This is your clavicle, and this is your middle of the clavicle, mid clavicular line. In fifth intercostal space, we will put our V V4 and V4 and V2. V3 will come between the V4, V2 and V4, right here. Now, V5 and for V6. For V5 and V6, here is your axillary, here is your axilla. Now, anterior axillary line is here, and this is your middle axillary line. So, V5 will be on the anterior axillary line, and V6 will be your middle axillary line. So, this is, let me show you, this is your heart, maybe. This is your heart, and I'm going to cut it like that, a coronal section of heart, and maybe a transfer section of heart, and I'm going to show you these again. This was my mistake. Transfer section of heart, again, the precordial or chest leads will give you the transfer section, right? Transfer section. So this is going to be your transfer slice of a heart. And here are the leads, your V1, V2, V3, V4, V5, and V6, right? Now these all are positive. These all are positive, right? And these leads are going to take electrical activity to different parts. Like V1 and V2, if we talk about V1 and V2, they will take from septum. And we talk about V3 and V4, V3 and V4 from anterior wall, and V5 and V6 will take electrical from lateral wall, right? So if we have any deformity or any electrical activity problem, we can we will know through these segments. So these all about our ECG. These all are about our ECG, right? Let's move ahead. Now, auscultation of heart. Auscultation is a very crucial skill, right? When you know the heart sound and you know the normal and abnormal heart sound, you will know any if there is any problem with the heart, right? So, normal heart sound we will talk about like S1. It is due to closure of a mitral and tricuspid valve. Beginning of systole contraction, location, its apex and lower left sternal border, right? So, as we talked about earlier, this is your clavicle, right? Here, your sternal angle. You will count to second rib, the second intercostal space, both side of sternum. You are going to get some hard sound, right? Then your mid clavicular line, fifth intercostal space, you will get another hard sound, right? Now, let's talk about S1, lower left sternal border. This is going to be your tricuspid. Its character is loud, sharp, and crisp because it is due to valve. The valve sound are always sharp and like a snap, right? The next, second heart sound is also closer of pulmonary valves, right? Its character is soft, sharp, and crisp, right? Now, let's move ahead. Here, the S3 sound is of ventricle, filling of ventricle. Now, this S3 sound is also going to be abnormal, right? We will discuss. Now, Its timing is early diastole, and its apex, its character is it is on located on apex, or obviously because it is on the ventricles. Now, character is soft, low pitched, and gentle. Right now, S4 sound is due to atria contraction, right? And this is also going to be abnormal. Now, pumping blood into ventricle, its key timing, like its timing is late diastole, location is on apex, character soft, low pitch, and gentle. Right now, next abnormal heart sound. So first we are talking about the murmurs, right? We are talking about the murmurs. So abnormal blood flow through valve chambers, right? Murmurs, you will listen murmurs when there is a turbulence in the blood flow, right? Maybe the timing of diastole. Again, I'm going to talk about S3 sound. If your abnormal S3 sound is due to your ventricle. Now, if the blood is flowing back and forth between your ventricle wall, you are going to listen a murmur sound, oozing, swishing, or blowing sound. Right now, this is your gallop rhythm. Extra hard sound, often extra hard sound when there is a fuel failure or volume overload. Right, its location apex or lower sternal border. Its character is rapid, rhythmic, and loud. Right now, clicks or snaps. Again, clicks or snaps is connected to your walls. Now, systole or diastole, its timing, wall closure or opening. Remember, in normal conditions, you will listen usually only closing of the wall, right? But not the opening. But during the normal condition, you will listen both. Now, location varies depending on valve involved. Obviously, if this are semi-lunar, then different location, and if they these are AV, then different location. Characters: sharp, clicking, or snapping. Right now, auscultation technique. Yes, we need very high quality stethoscope. Uh, Place the stethoscope on few specific points like your uh, uh, both side of the sternum, on your specific intercostal space and mid-clavicular line to hear the mid-clavicular line, fifth intercostal, to hear the sound. Right? Listen carefully, heart sound, noting, because as I mentioned, this is a very crucial skill, because you need a very close listening, right? And fourth point is sound different position, supine, sitting, or standing. You can hear this sound on supine position, sitting, or standing. Use the ball to hear low pitch sound and diaphragm for high pitch sound, right? So let's come to the final topic, which is phonocardiogram. It is nothing but connected to the sound. We have already pictured graph about our electrical activity, but what about the sound, heart sound? For this, we will going to use the phonocardiogram, because S3 and S4 abnormal sound due to atrial and ventricle problem, atrial weakening and ventricle back and forth blood flow into the ventricle walls. These can be here by phonocardiogram and also picture into a graph, right? Like here, a graphical representation of sound, right? Here, we have a simple graph, time versus amplitude. Amplitude is concerned with the intensity. We must know that how intense is going to be our sound. If it is more than usual, it is abnormal, right? Now, time. If there is a delay or premature sound, it is also a problem, right? So, hard sound S1, S2, S3, and S4, and murmurs. If we have murmurs, then we will also compare that how intense and how long are the murmurs. And also we will have here ECG. ECG, we both read PCG and ECG and connect them and we can compare at what time, at what specific time and what specific event this sound we can hear, right? So we can diagnose a whole problem. Now, identify characterizing heart murmurs. These are the use of phonocardiogram, diagnose cardiac condition like valve disorder, cardiomyopathy, monitor cardiac function and hemodynamics, evaluate the effectiveness of treatment. Right? This is also non-invasive, complementary diagnostic tool. Yes, this is complementary to ECG because this is going to help our ECG to know better the disease, auscultation, electrocardiography, and other cardiac tests. It provides more detailed and objective analysis of heart sound, helping healthcare professionals make accurate diagnosis and develop effective treatment plans. So this is all about modern methods to study heart, right? So thank you very much, and this is all about in this presentation. Thank you.